All right, I see many folks joining. And as we continue to welcome people in, I'd like to get started. My name is Allison Evans. I'm the President and CEO of Research Canada. And I want to welcome you today to our Parliamentary Health Research Caucus virtual event on breaking barriers in chronic pain and addictions research. We are very, very grateful to have all of you with us today, and we are very pleased to be providing this event in partnership with the Chronic Pain Network in what is a very important week, showcasing and casting an important light on chronic pain as a major issue, and noted that even Minister Sachs put out a very important statement about the significance of this as a real issue within our society, and so impressed by the researchers that have agreed to give their time today and our partners at the Chronic Pain Network for providing this event to all of you. Again, in a timely fashion on an area of very important health policy relevance. And I'm just going to say a few words before I pass it over to some of our sponsors. As you may know, our Parliamentary Health Research Caucus is a vehicle through which we bring important health research and innovation topics to policymakers, health stakeholders, and other decision makers across the country. We want to thank you for joining us today to learn more about this important topic. J'espère que vous êtes tous aussi impatients que moi d'entendre les experts d'aujourd'hui. Je voudrais maintenant remercier nos commanditaires pour leur générosité. Thank you to our co-host of today's event, the Chronic Pain Network. Your expertise has been invaluable in putting together such a wonderful event. I would also like to thank and recognize the 2024 lead sponsor of our Parliamentary Health Research Caucus, Innovative Medicines Canada. And I would also like to extend sincere appreciation to BD Canada, Admari Bioinnovations, and the Canadian Institute for Military and Veterans Health Research. Merci à tous pour votre soutien. And before I want to just give you a little bit of a sense of how this is going to go. Before we get into the panel with our researchers, we will hear a few short remarks from Innovative Medicines Canada, Admari Bioinnovations, and from our host, the Chronic Pain Network. So please join me in welcoming our first speaker, Sophie Normand, who is the Director of Federal Government Affairs at Innovative Medicines Canada. Sophie?
Thank you, Allison. It's a real pleasure to be here today. C'est un grand plaisir pour moi d'être ici aujourd'hui au nom de Médicaments Novateurs Canada on behalf of Innovative Medicines Canada to talk about this really important topic. I'm proud to be representing IMC today to support the Parliamentary Health Research Caucus. From being a co-creator and a lead sponsor of the Research Caucus, we find value in information transfers and know that meaningful and productive discussions happen here. The statistics around chronic pain in Canada are astonishing. Living with constant debilitating pain is the unfortunate reality for 1 in 3 people over the age of 65. This impacts not just individuals, but families, workplaces, and our healthcare system as a whole. At Innovative Medicines Canada, we believe in the power of scientific innovation to transform lives. Our member companies are at the forefront of developing breakthrough treatments that target pain at its source while considering the complex nature of chronic pain management. We're supporting research into novel therapeutic approaches that move beyond traditional treatments to offer new hope for those suffering. Today, I'm looking forward to exploring innovative approaches to break through barriers and forge a new path in pain management solutions. This is a really promising initiative, and we anxiously await learning the results of several ongoing clinical trials that could revolutionize how we treat chronic pain. Looking ahead, Canada has the potential to become a global leader in pain management research and treatment. With continued investment in research and development, and by maintaining our commitment to patient-centered care, we can create better health outcomes for millions of Canadians living with chronic pain. Today's panel will delve deeper into these topics, featuring leading experts who will share their insights on breakthrough treatments and innovative approaches to pain management. Together, we can transform the landscape of chronic pain treatment and bring hope to those who need it most. Thank you. Merci.
Thank you so much. And now it's my pleasure to ask Bethany Moore from Admare Bioinnovations to say a few words.
Thank you so much. My name is Bethany Moyer. I'm the Senior Director of Public Affairs at Admare Bioinnovations, and we're very happy to be among the sponsors of this event. And I'm so pleased to also just have an opportunity to tell you just a little bit about what we do at Admare. At Admare Bioinnovations, we believe that Canada's track record of scientific discovery can be leveraged to develop globally competitive companies of scale, improve patient health around the world, and significantly contribute to Canadian prosperity. So we are invested in building a national engine that helps to drive commercialization, create that next generation of homegrown Canadian anchor companies, and establish a globally leading life sciences industry from sea to sea, which is where our name, Admare Bioinnovations, comes from. So what do we actually do? In short, we provide the commercialization infrastructure, I'll call it, to help build companies, ecosystems, and talent. And this includes scientific infrastructure to validate ideas. We have a team of biologists, chemists, commercialization experts that will generate and test ideas, both ideas internally generated as well as ideas in partnership with our world-renowned post-secondary institutions. And if those ideas demonstrate some commercial viability, we launch a company. We then have the networks of expertise to accelerate company growth. And whether it's a company that we help to launch, whether it's an already established early stage company that's part of our Admare TX Accelerator program, or whether it's a company that's a little further along the commercialization pathway and part of our direct investment portfolio, we provide a suite of tailored services that include scientific and regulatory guidance, IP strategy, business development, lab space, and capital to help them more quickly achieve essential milestones. In fact, Admare is one of Canada's largest seed investors in life sciences, and we've developed that capital infrastructure to help bring other investors to the table as well. Physical infrastructure is another part of our offering. In Montreal and Vancouver, we offer state-of-the-art wet lab space. And finally, no ecosystem can exist without talent. And the Admare Academy helps to build that talent by training highly qualified personnel from undergrads to industry executives. Over the last 5 years, we've helped to build 36 companies. Those companies have raised more than $2.4 billion in risk capital and created around 1,000 jobs. And in the chronic pain space in particular, Neurothic Therapeutics is one of those companies that has some really exciting potential drug therapy that may provide a safer, non-opioid alternative to chronic pain patients. So I don't want to take any more of your time. I think we're all looking forward to hearing from this really knowledgeable panel of experts and learning more about the exciting research happening in this field of chronic pain and addiction management. Thanks so much.
Thank you so much, and agree. And just prior to starting our panel, it's my great pleasure to ask Dr. Norm Buckley, who is the scientific director of the Chronic Pain Network, to say a few words before we start our discussion. Norm?
That's great. Thank you very much, Allison. And we greatly appreciate the opportunity to be here today. We're very pleased to be co-sponsoring the event with you. This week in November, as you said earlier, is Canada's National Pain Awareness Week that was designated by the Senate in 2004. This is our opportunity to discuss chronic pain in Canada, to provide you with some context about chronic pain and its importance, as well as some information about the state of pain research in Canada. And not to put it too finely, to seek your support in increasing Canada's investments in pain research. First, the Chronic Pain Network. We are one of 5 chronic disease research networks funded by the Canadian Institutes of Health Research in 2016 under their Strategy for Patient-Oriented Research, the SPORE program. Our goal is to change the way pain is managed in Canada. This is admittedly a work in progress. However, we have established a national network of pain researchers, educators, and healthcare providers, along with a dynamic group of patients who have become a critical part of the process of pain research. This engagement from patients ranges from research priority setting through conduct of research and the dissemination of the results to inform healthcare and policy. The network was a driver in the creation of the Canadian Pain Task Force. This was called up in 2019 by the Honourable Jeanette Petitpas-Taylor, and in 2021, the task force gave us the Action Plan for Pain in Canada, Canada's strategic plan for dealing with chronic pain. Funding the network was a significant recognition by the CIHR of the importance of chronic pain as not only a symptom, but also a disease in itself. Long-lasting changes in our physiology that occur to turn acute pain into something that can last far longer than the recovery from the original injury or the illness that triggered it. And chronic pain sufficiently severe to affect daily activities occurs across the lifespan, from childhood into the senior years. Chronic pain in children can hinder their progress through school, hinder normal social development, interfere with family life, and prevent their entry into the workforce. In adults, it can affect the workplace with reduced productivity and increased disability. And in seniors, it may prevent the activities that are necessary to maintain good health in aging or even to worsen dementia. Chronic pain is expensive. In 2019, it was conservatively estimated to cost Canada nearly $40 billion, $40 billion. Half of this from direct healthcare costs and half from indirect healthcare costs, including lost income, lost productivity, disability, etc. That makes it one of the most expensive health issues in the country. Despite that, present annual investments in chronic pain research represent a very small proportion of budget for healthcare research in the country. The opioid crisis has shown us the extent of pain in Canada. Opioid prescriptions are almost universally written to treat pain, and chronic pain affects 20% of Canadians. More for some groups, such as military veterans, the aging, tradespeople, poor, Indigenous peoples, and other equity-seeking groups. The crisis has also highlighted the problems that flow from depending on a single solution to a complex problem. Many of our pharmacologic treatments currently available are only partly effective, including opioids. And they may have adverse events that are important, such as addiction, disorientation, etc., that make them unhelpful for many patients. Non-pharmacologic treatment, such as physical rehabilitation, counseling, recovery strategies, are often not acceptable or not part of our universal healthcare plans. So chronic pain is a complex problem, as I think you'll hear today. It's not well understood, and best care is not readily available throughout the country. Nonetheless, on the other side, we have some great successes in very high quality research, which you'll hear about. And Canada is recognized around the world for these contributions. And I think I'll turn the event back to you now, Alison, to hear a little bit about those other activities. Thanks very much again.
Thank you so much, Norm, for helping to put today's conversation in context. And certainly it is alarming to hear those figures, and we have our work cut out for us. And today we have some incredible Canadians with us who come at this topic from a variety of perspectives, and we'll enter into conversation with them. And please know, as a participant on today's event, that we will take your questions as well. And you know, we're going to have a conversation up front and allow each panelist to say a few words about how they perceive this topic and the work that they're doing. But by about 1:10, and for the remainder, we'd really like to make this interactive. And so please be listening with your own questions and thoughts in mind, because we'd love to have your engagement. And so without further ado, what we're going to do is ask each panelist to take 3 to 4 minutes to speak about this topic from their perspective. And I would like to start with Jennifer Daly-Sear. Jennifer is a patient advocate and involved in various pain networks across Canada. Jennifer, could you please kick things off for us?
Absolutely. Thank you so much. And thanks for inviting me to this panel. A very important topic today, as many of you have reflected so far. So my name is Jennifer Daly-Sear, and I'm a person living with pain, and I have been for over 10 years now. So just to give you a little bit of my story to put some context to it and support the research, I live in Ottawa, a populous and well-serviced city, as you know. In 2014, I was living the dream. A life of many privileges. I had a full family, social life. I had spent years building a professional career in marketing and strategic planning. I held senior leadership and faculty positions. I traveled extensively, and I had developed a passion for climbing mountains, including Kilimanjaro and to Everest Base Camp. In fact, I had just returned from my second climb of Kilimanjaro when I was suddenly struck with severe right upper quadrant abdominal pain. Despite numerous and continued investigations, I am one of the unknown number of Canadians without a diagnosis. In other words, there is no known cause for this pain, no treatment beyond symptom management. And frankly, I've lost count of how many times I've heard, "You are my mystery patient." Over these 10 years, I've visited emergency rooms. I've seen over 30 doctors across 20 specialties. Eventually, after a year and a half, got access to the pain clinic. I've had over 40 imaging appointments, procedures, surgeries, and countless lab tests. Tests that would come back normal or inconclusive, having me start all over again. And that's a lot of time and cost to this healthcare system. You can only imagine the extraordinary amounts of time for me waiting to get into appointments, to and from appointments, note-taking, let alone the impact for me trying to understand the healthcare system and my condition. And I still don't know why I have this painful and invisible condition. Despite the efforts of terrific doctors, it remains unsettling to me that I'm left wondering, has something been missed? All of this in the best of settings, our capital. Like so many others living in pain, the impact has been massive. The impact, it has an impact on the whole person. And by that, I mean the sort of bio, psycho, social, spiritual side of an individual. While I've made some recovery, I continue to be learning how to live with severe acute episodes of persistent abdominal pain. I consider myself having privilege. I have access to good health care, and yet this is what's happened. I cannot imagine if someone else who has less access, for example, whether that be geographical or other life circumstances, or having less comfort journeying through the healthcare system, what it might be like for them. It's not easy to be ill and to try to figure out the healthcare system at the same time. Being a part of pain research and healthcare improvement initiatives draws on my expertise by lived experience, and it draws on the many skills I developed through my professional career. I've been able to be involved and make a contribution to national, provincial, and university research projects and initiatives, including as co-chair of the Executive Committee for the Chronic Pain Network, as board member for Pain Ontario, as well as a founding member of the steering committee putting the Pieces Together conference that is ongoing this week and was opened by Minister Sachs on Monday. I am but one example of a person living with pain, and people like me are simply trying to learn to live with the pain, and are doing their best to manage it and to live their best life. And with that, I want to thank you very much to the Parliamentary Health Research Caucus and the many parliamentarians, policymakers, researchers here today for your efforts to improve the state of pain and the healthcare system's response to pain. Today gives me such hope for the future of pain. Thank you.
Thank you so much, Jennifer. And I really commend you for your candor, your courage and your willingness to share, because as you point out, there are likely so many others who unfortunately experience debilitating pain and may be struggling to access support. So I can't thank you enough for your advocacy and what you've shared with us. And I think it helps us really consider what is ahead of us in terms of progress in this area. So thank you very much. And it's my pleasure now to introduce Dr. Yves de Koninck, who is a professor of psychiatry and neuroscience at Université Laval. He's also a Canada Research Chair in Chronic Pain and Related Brain Disorders and Director of the Cerveau Brain Research Centre. Yves, would you like to take a few moments to introduce yourself and your work, please?
Thank you, Alison. Yes, I represent here on the panel the scientist, the person who's been trying to understand pain mechanisms and especially chronic, abnormal, pathological pain over the years. I've been engaged in this for, well, many years, over 40 years. Starting as a graduate student and in setting up my lab and now leading the Cerveau Brain Research Center. I also founded over 20 years ago the Quebec Pain Research Network, which is a wonderful network of scientists and clinicians and patients and decision makers that are engaged in a very strong dialogue to bring research to the bench and help transform also our healthcare system. It's been funded by the Fonds de Recherche en Santé du Québec in Quebec, and it's been really a wonderful tool to advance the research portfolio and its translation. So I'm here to tell you that, us working in the lab and trying to understand pain, of course, trying to help diagnose, accompany people and try to reverse pain or prevent the development of chronic pain or reverse chronic pain starts with understanding pain, and especially chronic pain, where the nervous system goes awry and therefore something that should not be producing pain suddenly is producing pain, and it just doesn't go away. We have a lot of strength in Canada. I would submit to you that actually Canada is the strongest country in the world in terms of pain research. This is determined by bibliometric analyses that are showing that in terms of impact on the scientific, by scientific indicators, Canada has a very, very strong, it is the strongest country in terms of quality and impact of the research. Research in chronic pain and basic research into understanding the mechanisms of chronic pain has a number of important outcomes. One of them, of course, is to discover the mechanism, what has gone wrong, and how we can identify novel, what we call in the industrial world, novel targets to treat pain, which will lead us to develop new drugs, to target drugs that are alternative to the existing drugs, including alternative to opioids, because we really need to broaden our portfolio of drugs to cure chronic pain. On this front, I'd like to mention that it takes time to bring novel drugs to the market. We can discuss that. We used to say 15 years. I would say it's about 25 years of work to really bring a new medicament to the table. And many of the discoveries that are converging now into new drugs, prospects for pain, started 20 to 30 years ago. And what's actually very encouraging is we're witnessing the convergence of many discoveries that are bringing now new prospects, akin to what happened with the wonderful transformation of vaccine development for COVID, that really built on 30 to 40-year-old discoveries that all converge at one point. And we all witnessed the miracle of how fast we were able to develop a vaccine. And I think the same is happening for chronic pain. There's good optimism to be there. But understanding chronic pain is also very important not just to develop new drugs, but also to develop a number of non-pharmacological approaches and improve non-pharmacological approaches to what I say tap into our brain's ability to control our own perception of pain and actually tap into our own ability to repress chronic pain, engage ourselves into a therapeutic in the therapeutic path into recovery. And these non-pharmacological approaches are not a contradiction of the drug-based approach. They are a real continuum, and research is demonstrating that there is, very sound scientific reasons why meditation, for example, can be very, very effective at recovering from chronic pain, just to give you an example. Another, I think, very important aspect of, and the Quebec Pain Research Network has been very active there, and a major advance that research on the mechanism of pain has a very important impact is into destigmatization. We all know how stigmatizing chronic pain is, and I think research, basic research, has been very instrumental because we have been able to demonstrate that chronic pain is a real phenomenon. It is a real pathology, a real disorder of the nervous system. Therefore, it's a real phenomenon. It's not just, this person is just complaining, blah, blah, and so on. You're just a whiner and so on. No, it is a real problem, and it therefore has to be targeted directly. Pain is not just a consequence of something else, and therefore we have to solve the other problem and not pain. The demonstration that there's a disorder of the nervous system has made the entire scientific community, focus on the mechanism of chronic pain to find solutions. And it still is a very young area. Basic research into mechanisms of chronic pain is only about 35 years old. We have a lot of expectations, but keep in mind what I said about, the drug development path. But also, I think the research, and going back to Jennifer's comment, as also helping us a lot understanding chronic pain, helping diagnose chronic pain, put a finger on what goes wrong. That's the drama that she described of never really understanding what's wrong with me. We are now developing a lot new tools now to detect much finer indices that are telling us what this pain or that pain is. And the clinicians that will talk after me can say more about this. I think I would like to submit also that research and pain research has helped us, and I speak from the perspective of the province of Quebec, has really helped transforming the healthcare system. The Quebec Pain Research Network has worked very well with the Ministry of Health in Quebec to create tertiary care centers of expertise for the management of chronic pain through a very multidisciplinary approach. And also there, I think Canada and Quebec are pioneers in the world. It's still funny to say that, but direct management, first line, approach to handling chronic pain in our health system is relatively rare across the world, and the creation of centers of expertise in Quebec in the different health networks across the province has been a real landmark, and research has been a driver for that through the demonstration of that we have to target chronic pain. Maybe one last word, Alison, if you want to talk about addiction. One of the things that our research in my lab and others have shown is that we are understanding better and better now the mechanisms of opioid action and actually the reaction of the body to opioids, and the fact that actually we are discovering that the adaptation of our body to opioids can be a source of the dependence on other opioids and leading in some cases to abuse of opioids. This understanding is very important because it opens other avenues for alternatives to opioids, but also actually we're discovering ways now to improve or prevent some of the side effects of opioids so that, hopefully we can better use opioids in the future. And there's a nice convergence of discoveries with positive prospects.
Excellent. Thank you so much for those opening ideas. Lots of possibilities to come back. I'm sure there's many topics that you've illuminated that people will want more information on as the conversation goes along. And now it's my great pleasure to ask Dr. Elena Lopatina, who is the senior scientist with the Alberta Virtual Pain Program and the Alberta Pain Strategy at Alberta Health Services, to say a few words for us as well.
Thank you, Allison, and thank you, Eve, for starting this discussion. The basic science is foundationally important. Once we understand the pain pathways, the mechanisms of pain, and develop those pharmacological and non-pharmacological approaches to pain management, we also need to make sure that those approaches are implemented and are accessible to patients. And this is where health services research, social sciences, health policy comes in action, and I'm representing this perspective on the panel. My research focuses on measuring and understanding the impact of pain and chronic pain specifically, understanding the gaps in practice and care, developing and implementing solutions that can address those gaps, and also evaluating current and new health services, practices, and technologies to make sure that they are safe, effective, and meet the needs of both patients and providers, as well as the healthcare system. And in this work, I partner with communities, patients and caregivers, providers, health system operations, and decision makers to co-design this research and co-design the services and solutions. One thing that I would like to highlight is, despite the immense impact of pain on patients, societies, health system, country, there's still often not enough attention to pain in terms of both health services delivery and research. We've done amazing work in Canada, but way more needs to be done because of the demand and because of the impact of pain on our lives. And as my mentor, Tracy Wasiluk, who's a great health innovation leader from Alberta, would say, pain is everyone's problem. Every physician sees pain, every healthcare provider, but pain is no one's business because it's everywhere, but there's not enough focus on addressing this problem. So it is critically important to prioritize pain, both in terms of health services and research. And Alberta is a great example how prioritizing pain can actually lead to change in practice and policy. I started as a postdoc with Alberta Pain Strategy, and now I'm a senior scientist with the Virtual Pain Program and Alberta Pain Strategy. The Alberta Pain Strategy, Alberta was one of the first provinces in Canada to have provincial vision for pain management. So in 2019, patients and providers joined Alberta Health Services to develop this provincial vision, Alberta Pain Strategy. And the vision of the strategy is to ensure excellence in pain management across the continuum of life for all people of Alberta. And the strategy identified 3 priorities: acute pain, chronic pain, and opioid management in pain as well. And chronic pain has been one of the operational priorities for the province and the provincial healthcare delivery system. And research was done to identify the gaps, identify where there are strengths, how we can improve it. And also a lot of advocacy was done to share the findings of that research, to share the burden of pain, to share those gaps that we have, and also suggest how we can make it better. So as a result of that advocacy in 2022, which was 3 years after the start of the strategy, the government of Alberta committed to dedicated funding for a provincial pain program and launching the first phase of this program, focusing specifically on chronic pain. In spring 2024, the virtual pain program was successfully launched, and to date, hundreds of patients already reached out and were able to access care that they were not able to access before. So I think it is really important to prioritize pain and also work together across the whole community to make sure that the research that is being done is shared and also informs policy and practice.
Excellent. Thank you so much for those perspectives. And it will be interesting to come back and talk about how the successes that you're seeing in Alberta can be, shared and help inform progress in other parts of the country in our conversation. And last but not least, it is my pleasure to ask Dr. James Kahn to share an opening with us. Dr. Kahn is a clinician scientist at Sinai Health in Toronto. Over to you.
Thank you. Thank you, Allison. And thanks for having me this afternoon. As mentioned, I'm a chronic pain doctor as well as a clinician scientist at Mount Sinai Hospital in Toronto. And I lead a clinical research program focusing on identifying novel interventions that either prevent or treat chronic pain. Now, as a practicing chronic pain physician, I can attest to the fact that current treatments are only mildly effective. And it is very rare that we ever achieve resolution of pain in a patient with chronic pain. And so what ends up happening is that we have a scenario where every year there are new cases of chronic pain and very few patients who will have their pain resolved. And so it's not surprising that we have an ever increasing burden of pain on society and the healthcare system. So from a health economic point of view, if you will, it might be more fruitful for us to investigate ways to prevent chronic pain before it occurs, before we achieve and identify effective treatment options. Now, the problem arises is that we don't know when the next car crash will happen, or we don't know when that patient will start feeling their arthritis. But what we do know is the time, date, and place of the next surgical procedure. And in fact, surgery is responsible for 1/4 of all chronic pain in society. And because we know when the next surgery will occur, this gives us an opportunity to not only intervene at the time of surgery to prevent chronic pain, which is known as chronic post-surgical pain, but also use this opportunity to understand how pain transitions from acute pain to chronic pain. So my research program is focused on that, to identify those undergoing surgery who may be at greatest risk of chronic post-surgical pain, but also identify novel interventions that could prevent chronic post-surgical pain. We're currently focusing on 2 high-risk populations. One is breast cancer surgeries, and the other is total knee replacements. We are currently leading one of the largest studies in the world, evaluating a simple drug, lidocaine, most of us know of it, but infusing it into the bloodstream at the time of breast cancer surgery. What's often not realized is that breast cancer surgery is associated with one of the highest rates of chronic pain. 1 in 3 patients undergoing a mastectomy or lumpectomy will develop chronic pain. We have enrolled about 1,000 patients across 15 sites in Canada, and we're expanding to 3 international sites to finalize a definitive study of whether lidocaine infusions can prevent chronic pain after breast cancer surgery. We're also starting a study in vitamin C, looking at whether vitamin C can prevent persistent pain after total knee replacements. Total knee replacement is an interesting surgery because it is one of the most commonly performed surgeries worldwide. It is actually number 3. And by 2030, it will increase by 130%, given our aging population. There has been some data that vitamin C, a simple supplement that can be obtained over the counter, can prevent pain after orthopedic surgeries. And we're conducting a definitive study to look at that. So our program is the, I'd say, the last stage of the bench to bedside pathway. And we hope to evaluate simple, low cost, widely available interventions and whether they can prevent or even treat chronic pain. And the reason we're focusing on these types of interventions that we strongly believe in access, something Jennifer alluded to, is that if we're truly going to make an impact on patients with chronic pain, identifying the targets or the mechanisms or drug is important, but also is important to realize how do we get this into the hands of patients, and simple, low cost, widely available drugs or supplements can allow us to get these interventions in the hands of patients easily.
Great. Thank you so much for that intro. And now we'll bring everyone involved in the panel up onto screen. And as that's happening, I hope people can see that in the chat. I've said thanks again for joining us. It's an incredible opportunity we have in this important week to talk about this. And I really think our panelists have really set the scene in a very compelling way. And I must say, many of your points and stats and stories have really struck a chord with me. It's if you haven't experienced this directly, many of us think of pain as something that comes and goes in a much more temporary fashion, even if it is acute. It's absolutely so disheartening to think of what it must feel like to have persistent and inexplicable, in some cases, pain that really changes one's life. And so thank you so much. And there's a lot of interesting things that you've brought up. I think what we want to try to do today through this conversation is not only maybe come away with a sense of where is Canada, shining, where are our strengths, what are we hopeful about, but also what are our gaps? What's where at the end of the day do we want to see ourselves if we look ahead 3-5 years, given the enormity of this problem, given an aging population, and given also that we find ourselves in a moment in our history with record low productivity already, coming out of a pandemic that has caused all kinds of health issues, not to mention mental health issues as well. So I believe this chronic pain theme is very much intertwined with some of those other phenomena. And I think I'd love to continue this conversation. So perhaps I'd like to go back to Jennifer, who kicked us off by sharing her story, and just ask you, Jennifer, when you hear about some of the work that's going on in parts of the country, and whether it's around drug or non-pharmacological interventions, some of the solutions that James and his teams are looking at, or even the measures being taken in Alberta, what are some of your reflections as someone with lived experience? And you're on mute. Sorry, Jennifer.
There we go. I hit the wrong button. I finished off earlier by saying that this panel gives me hope for the future of pain. And I think, hearing from each one of the panelists continues to support that very deep felt feeling. Certainly from my standpoint, before having pain myself, I did not understand what it meant. I didn't understand what acute to chronic meant. While I was going through the process, didn't understand it then either. And it's taken me years to kind of figure it out. And I continue to feel that should be, as Eve said, a curable or perhaps reversible thing. I keep that in my heart. So from that standpoint, those pieces are incredibly important, knowing that there's work going on in that field very directly. I think about the impact on the medical system of acute to chronic as well. And I mean, I've come to see my own very high use of the medical system, no doubt. But, the cost to the system by not being able to predict these things earlier on or treat them earlier on, I think is really to be underlined in that respect. And I don't know the dollars related to that, but I certainly can see the impact that it can have on an individual as well as the healthcare system. I think, losing one's identity or losing one's what they knew before to go to, a different day when you're experiencing pain is hard enough. We just want to be able to see that there's some hope in the future and that there is potential. I think as much as there is so much research going on, and I was incredibly blown away when I first heard about research involving patients, for example, involving people with lived experience. In fact, that drove me to want to be involved very much. it's imperative that that continue and find a way for that to continue. And so then people can also learn how to navigate the system and have the conversations with their clinicians and all of these things that are peripheral to the important research that's going on.
Quick follow-on question, and then I would
Mhm.
invite the panelists to also weigh in on this is, Jennifer, do you feel that there amongst sufferers, there would be a willingness to participate in trials and studies? And do you see any barriers to us being able to ensure that clinical trials and other types of research are being able to connect well with people who stand most to benefit? Or is there a gap between connecting, the researchers with patients and people who would be willing to perhaps help move things forward?
My view is that there's a couple of layers to that question. One is everyone's experience with pain is different. And so therefore, willingness or comfort level perhaps in participating in something is different. I think the engagement of people with lived experience has varying degrees of application. And so folks understanding right up front, what is the expectation? Can I do that? How can I bring my skills to the table to enhance the situation? So there's clinical trials, but also the research that Eve spoke to that takes up to 25 years to get to the table in terms of medication, for example. I think, it's about how people are engaged and helping them understand that. That said, the Chronic Pain Network is playing a major role in terms of connecting patients to researchers, whether it be basic scientists or clinical researchers, and trying to connect them with patients, not as the primary role of connect them, but getting to know patients, how they work, involving them, integrate them into absolutely all aspects of the organization, and provide, say, opportunities. I think there's a lot of teaching and learning going on with respect to patient engagement. There's still a road to travel there in terms of consistency of application and how that's done. And but I think the opportunities are there. And yeah. So does that answer your question?
Yeah, it does. Yep. And I would invite everyone, including Norm, from where you sit at the Pain Network, to let I think it's really important that we understand the patient piece in this, and if there's any sort of barriers or hurdles between connecting the good work that's going on with people who stand to benefit and who may be willing to be directly involved, but may not know of those opportunities. There may be barriers to participation, et cetera. I'm just curious what everyone thinks before we delve back into some of the science.
Thanks, Alison, and and thanks to all the speakers. And I've been seeing some notes appear in the chat which are relevant, I think, including Ken Craig, who's one of the grand originators of pediatric pain research in Canada. Has been a sort of an inspiration to many of us over the years. I think Eve nailed it when he said that in many ways, pain research in Canada, and to some extent the world, is a relatively young science. Canada has had the opportunity to make remarkable contributions to that. People like Ron Melzak at McGill, for example, who in combination with Pat Wall laid out the gate theory of pain, a remarkable conceptual approach to pain. And there are things in Canada which are really groundbreaking, and also in the pediatric pain research area. There are some really remarkable gaps. Even though we have many academic pain clinics across the country, it really wasn't until the first iteration of the Chronic Pain Network, where we brought a number of those together in what we call the Clinical Research Network, and put research infrastructure in place to support clinical trials being conducted at those centers and try to support multi-site studies, which, certainly in the pharmacologic world, multi-site studies are critical to getting enough exposure to really assess the effects of a new intervention. Now, that is a piece of infrastructure which doesn't really exist. And so, we had some success for about 5 or 7 years. The funding now is limited for that, and we're seeking other sources of funding to support it. But when you think of the advances that have been made in things like HIV research and cancer research in the past 20 or 30 years, those have come from really intensive investments in research infrastructure and highly focused projects to conduct interventions. Pain is interesting because, like many chronic diseases, it encompasses not just the physiology of the disease, but the effect on your life of the long-standing pain. And we conceptualize pain as what we call a biopsychosocial disease. There is a biological element, and Yves referred to that, and basic science researchers are identifying those mechanisms. But it happens in the context of an individual who has a psychological history, a behavioral history, a learning history, and it happens in a social setting. And when we talk about things like the impact on the workplace, those are as a result of social policies, workplace policies, workplace management. So to really effectively deal with these things, we have to try to corral all of these kittens in one place and get them pointed in the same direction. And that is really challenging. And so then you have to figure out who is it that will have an investment in doing these complex interventions. And so that, I think, is one of the challenges to pain. Although I think there are some real opportunities right now to build on what was started by CIHR with the Chronic Pain Network and the other chronic disease networks in supporting that kind of complex infrastructure. It makes things like running multi-site trials, what James was describing, in some ways, came from work that, the CIHR is now supporting the Accelerating Clinical Trials platform, right? To try to expand Canada's ability to conduct clinical trials. And not solely, James has done a lot of this work himself, but he's benefited from some of that support and infrastructure in the ability to reach out and engage multiple sites around the world in this really important and novel clinical trial. So I think there are, some of the barriers are infrastructure barriers that aren't being applied to chronic pain right now.
Excellent. Thanks, Norm. And thanks for rounding out some of the picture for us. And James, Yves, okay, Yves, you wanted to get in on this topic? Yep.
Well, I think I can't reinforce more the Norm's comment about infrastructure because I think we need to insist on the fact that pain, chronic pain, and all the mental disorders that are associated with it is the most complex problem in the world. The brain is the most complex organ in the universe, or the one that we know at least. And it is a major problem. So when Norm says, look at the success that we've had with other diseases when we actually put all our efforts together, and HIV is a wonderful example in the COVID also. We are dealing with the most complex problem. So we definitely need to put all our efforts together. And the concept of an infrastructure that allows every component to be working in synergy is, I think, really crucial. So, and back to the patient and your comment with your discussion with Jennifer, it's an absolute essential component of this. We as researchers, we've tried to foster this within the Quebec Pain Research Network, that we constantly need to understand better the problem. And pain is such an chronic pain is such a heterogeneous condition. We need to have a very active dialogue with the people suffering for us to understand better the problem and whether what we're working on is actually relevant to this or that condition. It's not enough though. We need to have every aspect of the entire pipeline to be able to work actively together. And the network structure that our funding agencies have funded is a great step. As Norm mentioned, we have also, the healthcare infrastructures that needs to be integrated, actively into this, so that we can really have, when we're dealing with the brain, we're dealing with every aspect of our life, as Norm said, from the bio to the social to the, psycho and the social aspect. Think about it. It's just so complex. It's not just a biological disease. It's every aspect of our life. So we need to integrate. And I myself am an infrastructure man. I developed a research center, and when you put the convergence of every actors together, you can make wonderful things. We need to do this at the national level.
That's a very compelling ask and a great thing for us all to strive for. And in theory, some of the structural changes that are being proposed across the tri-agencies, and the introduction of a new capstone organization that would be a sort of a one door for multidisciplinary at those extremely high and important levels that you describe, Eve, as chronic pain really being a part of, as well as international and other types of mission-driven research that go beyond the boundaries of, what has traditionally been CIHR and CIRC, or social sciences and humanities. So in theory, the magnitude of the types of problems we face, whether it's chronic pain or AI or even climate change or things of that magnitude, increasingly demand a very holistic and multidisciplinary view. And before I move on to questions, and I really appreciate the ones that are coming in the chat, we will get to those. I just wanted to ask James or Elena if they wanted to talk a little bit about how they view patient engagement from their standpoint, and what's working well, and what do you feel is areas for improvement there?
Of course, happy to talk about that. I think it is particularly important to work with patients from the very early stages of research, starting from identifying priorities and questions that we're working on, to conduct research and then disseminate this research. There are opportunities to work together and develop that knowledge and share it together. And I think that is the most efficient way to do it. So in Alberta, we actually have a program where we train patients to conduct patient research. So patients working with patients to gather insights on their experiences with care. And often in chronic pain, patients are so lost and so desperate with the care that the little pieces of care that they get sounds like something, at least. So when patients get attention from traditional academic researchers, even that attention is already good to some extent. So often we don't really hear what they deeply think inside, what they think when they can't find care, how they feel about it. So having patients talking to patients really opens perspectives to getting that deep understanding of what's actually happening. And it is sad, and it is very, very challenging. Patients have to say that they have to fight for the care. They struggle, and it comes consistently. It's not one individual, it's many stories. So gathering those stories can help us understand what actually happens, but it can also help us translate the impact of pain. Because if we hear one story, we might think, oh, this is one individual, no one else has to deal with it. No, it is many, many patients in Canada trying to find care, trying to live their lives and try to get better or prevent getting into the state of chronic pain. And getting those experiences together and sharing them and having patients share them, I think can get more attention from both decision makers and funders to prioritize this research, to allocate that funding to those research institutions, and also to implement research within the healthcare systems. Because there should be active collaboration between healthcare system, policy, patients, to have that machine of research working so that we know what we're doing right now. We know what we're implementing. Is it effective? and then we can also react on the findings of that research instead of waiting 10 years to implement some changes.
Yeah, I think that's a really important point about the need to adopt and implement what we learn to be, an improvement in a standard of practice or an improvement in clinical care. And I know that as Canadians sort of look at our overall healthcare system and in its current state, I think we all are hoping to see increased receptor capacity of the healthcare system for innovation. It's going to be so critical because one of the worst, I think, things could be that if there are actually improvements in treatments and care that are possible, but just not accessible for a variety of reasons, and they're not being adopted or implemented. We have a long ways to go when it comes to moving new knowledge and solutions from discovery through to adoption and accessibility by patients. And I see Jennifer wants to respond, or Elena, did you want to expand before we go to
just
Jennifer?
to expand, because you said an excellent point. There should be reception capacity, but I also think that healthcare system shouldn't be just a receptor. They should be an actor in this work.
True.
They should be actively participating to make sure that there is this ongoing implementation and innovation.
I appreciate that, because I think that's actually what you were trying to say, is it needs to be bi-directional, right? And that's why clinical clinicians like James are right at that front line of where you can actually try things and get instant feedback and use that as a very positive loop. So James, I don't want to not hit you on this, but Jennifer, was something that came up, something you wanted to get back in?
Yeah, just in relation to that. So just with respect to, the healthcare and responsiveness of the healthcare, a comment is, I recognize as a patient that physicians are limited in terms of the amount of time that they have to meet with you. And I think that in itself is a challenge within the system. So while not necessarily directly related in terms of research, it is a challenge in the system. So if you only have so many minutes and you're trying to understand who that person is, what they're coming into the room with in their backpack, and you've got less than 5 minutes to do that, it's not a fault of the physician, it's a system. Imagine a world where there was that more time and we could, more could be accomplished upfront that perhaps saves time and dollars down the road. So I just offer that.
It's a tremendous point. 10-minute doctor visits, if you can even get one, are certainly not sufficient for an issue of this complexity, as you say. James, would you like to get in on this?
Yeah, I'll just weigh in with 2 points. One, with respect to engaging patients in research, I think it's super important from a knowledge translation perspective. And I think traditionally, most of research, how it gets implemented into practice, has been utilizing kind of a top-down approach. So having the investigators and clinicians present at conferences, publish their work, which is largely read by other clinicians or investigators. But what's very interesting, I think, with the chronic pain population is that they talk amongst themselves. There's a lot of support groups, there's a lot of circles. And I actually have patients coming to my office and advocating for themselves and saying, hey, I want to try this drug or that drug. And in fact, that lidocaine study that I mentioned earlier, one of the difficulties for us to recruit is actually patients coming into the pre-op clinic asking for lidocaine. They said, I've read about your work, or I've heard about the study. I don't want to be part of the study because there's a 50-50 chance I could get lidocaine. I want a 100% chance I can get lidocaine. And so I don't want to be part of the study, just give it to me, which I think is a powerful, thing to recognize. And is that if we are able to identify things that are effective, maybe this not only do a top-down approach, but maybe a bottom-up approach where we engage patients, engage the community. And so they are the agents of change, not only for their own care, but for policy making as well. The second point I want to raise is engaging patients into research in terms of what's actually allow research to get done. So we have guidelines that actually inform what questionnaires we should use during a clinical trial. But in fact, during our trials, we get a lot of feedback from patients that these questionnaires are too burdensome. And many of them will just stop halfway. And we can see that on our database, that they got through the third questionnaire, and then the fourth and fifth are not complete because they just got tired and they're done with them. And what does that leave with us? Incomplete data. And we actually can't make meaningful results. So while the guidelines suggest one thing for research, we have to be practical and feasible to what the patients want. If the questionnaires are too long, we need to adjust those to make them, practical to actually getting the research completed.
Excellent. And Norm looks like he wants to weigh in, but I just wanted to say a couple things really quickly. It would be interesting to hear from any of you what you think the power of AI might be for improving the administration or other parts of your research. I know that's sort of a pervasive question these days with researchers. But Norm, you wanted to respond to something, and then due to the great questions that are coming in on the chat, I'm going to try to summarize a couple things and then start posing some of them to the panelists. And just so folks know that with about 5 minutes left, I'm going to ask the panelists to each talk about what they'd like to see for the future. But in the meantime, we're more than happy to pose lots of your questions toward them. So keep things coming in the chat. Norm, over to you.
Yeah, no, I have also been watching the things in the chat a little bit, and I just wanted to reflect on a couple of them. One is, and Elena's referred to this also, the value of improving our efforts at knowledge mobilization, making sure that practitioners, that systems, and that the public are aware of what's currently considered optimal care for things like chronic pain, so that, as James says, they know how to advocate for themselves when they arrive in a physician's office. You don't know how to ask for the most useful thing if you don't know what it might be. And there are a number of things going on, and as much as part of me complains about what a difficult life we have and how many challenges we have in the chronic pain research world, there have been some remarkable things, including the action plan and the strategic direction that's laid out. And that's created something called Pain Canada, which is working to greatly enhance public awareness of what's going on in the pain world, what resources are available, and also to support the creation of peer support groups, which can make a more educated patient population and public about chronic pain. One of the things we know how to do a lot of things very well, but for a variety of reasons, and again, Elena's referred to that in terms of a system, systems do not always support our ability to do this. And for example, unrelenting pain is the most common reason to request medical assistance in dying. And yet we can do a remarkably good job at treating many forms of unrelenting pain with not just medications, but better delivery systems for medications. And on the other hand, we are often not in a position to provide that care because we don't have the resources or the space or the properly trained people. So I think there's a huge role for improving knowledge mobilization so that we make better use of the things we already know how to do well. I think that's critical.
That's a great point. Eve, you wanted to reply to that?
Just to add to Norm's point about the knowledge mobilization and resources, what's also important are resources where there's also some good vetting of the information that we can really guide the patient. So not just ad lib resource. If I can mention one effort in Quebec, there's a very nice resource that's led by the Quebec Pain Research Network and Dr. Anne-Marie Pinard. I'm just going to put it in the chat. It's called Gérer ma douleur. Of course, it's a French site, but there's an English on this. But this is actually a nice effort to provide resources to patients, practitioners, and researchers. So I think these efforts are quite important.
Amazing.
Maybe back to your, I don't know if you want a comment about the AI aspect, but I think in the scientific world, AI is a wonderful tool. It's not going to replace other things. It's a wonderful tool. And back to the concept that chronic pain is such a complex phenomenon. It's one of the places where AI becomes such a wonderful tool because it's so multifactorial, and we need to be able to detect things that are subtle and so on. That's where the AI is a great tool for us, not just in the management, but also in the understanding in the just the diagnostics of chronic pain.
Thank you for that. I just wanted to, and Elena, I couldn't help but think you might want to talk about how you're engaging in knowledge mobilization, but just let me address a couple things really quick. I wanted to thank Yad for sharing his resource called the Power Over Pain Portal, which is at the intersection of chronic pain and mental health. And I wanted to thank Ingrid for sharing some of her non-pharmacological approaches to managing pain, because back in Yves' introduction, he talked about promising practices there and mentioned meditation. And through Ingrid, we've seen a few more examples given. And Ken has talked about how important it is to acknowledge pain as a complex experience with cognitive and emotional as well as sensory features. So thank you for that. And I'll pause there, but we're going to keep going through what people have been providing and or asking. But Elena, did you want to jump in on either knowledge translation or AI?
AI was the first one, but yes, definitely happy to talk about knowledge mobilization as well. With AI, I think it is a very powerful tool. There are challenges with implementing it within the system, ethically and safely using it in research. But one of the challenges I think that is particularly big in chronic pain, and Carol alluded in comments very well to it, that social determinants by psychological and social determinants of pain. And unfortunately, to understand that and for AI to be a useful tool to help us understand it, we need to have data. We need to have data about patients, including data on social determinants of health. And unfortunately, because there is this separation between medicine versus social services, there is often not enough data that is connected together so we can actually understand it. And as it was James mentioned, it is very challenging to collect data. It is very burdensome on patients. But also, if we don't collect it, we won't know. So having, in terms of knowledge mobilization, probably just mobilizing the knowledge about the importance of data and importance of research in our society would be another important thing.
I couldn't agree more, Elena, and I'm sure most are aware at how many of the regions and folks here in Ottawa as well are trying to crack, the nut that is a national approach to health data. It's another area where many Canadians actually want to provide data if it serves better research, better treatments, and yet we seem to have some systematic or regulatory or other privacy issues that are preventing us from really getting there as quickly as we might like. But certainly there's a lot of good efforts underway. And I noted that Maria sort of was doubling up on what I had mentioned with the Capstone organization committed to multidisciplinary. I do definitely think that this is the type of major health issue that could be we could share with the tri-agencies the importance of this, finding a good approach through the granting agencies and the Capstone, as well as data. These are ones that are being pushed. The talk is, I believe, being recorded, and so to whatever extent we can share details, and or I believe the Canadian Pain Network might make some resources available. So for people on here today, we can do a follow-up to thank you for being here and share some additional resources with you. And we can certainly include any of the resources that have been shared in the chat. I'm just seeing if there's any other particular questions that I wanted to get to. Some of these are comments. How are interdisciplinary and intersectoral approaches being leveraged to address chronic pain management? Actually, this was addressed a little bit by Elena because she did talk about social determinants of health. But is there anyone else who wants to expand on some innovative strategies or models that are maybe already being used in some jurisdictions to prevent or manage chronic pain? Go ahead.
I don't know if I can give examples of industry efforts, but I would certainly reinforce what you all said, Alison, about the importance of it, of infrastructure that really connects all of the elements, as Norm also mentioned. And as you said, the transdisciplinary approach, again, because the problem is so broad. And again, we have the best scientists. We just need to connect the dots. There is also a comment to be made that connects to one of the comments by Shelley about having our own Canadian solution, not just depend on going to the US for and waiting for the US, for example. And that's again because it's a biopsychosocial problem. So the cultural aspects are critical. Language, just language. Think of language barriers. You need to address the problem in people's own personal cultures. So there is a need for that infrastructure in Canada and the efforts to be done in Canada, not just wait for the others.
Yeah, absolutely.
Yeah, I think the Quebec example of a very transdisciplinary approach within the Quebec Pain Research Network that really connected every aspect. In fact, I would argue that the Quebec Pain Research Network has been very instrumental in supporting the creation of the patient organization, which then became an absolutely essential component in the loop and in the dialogue with the Ministry of Health and in the implementation of the continuum of care by the ministry. So I think it's a good example. I go back to what Norm said, the power of networks. I mean, the Quebec network is one, and the Canadian Pain Network is of course an even bigger one. Of course, there's the provincial, federal barriers because the healthcare system is in the provinces. The federal can only do a certain amount. I think we have examples where we can help connecting them. I mean, the CPN the Canadian Pain Network is one example. At the federal level, I was the chair of the board of the Institute of Neuroscience, Mental Health and Addiction at CIHR. There's been enormous effort done at the level that the federal agencies can to try to connect the integrated youth health system. This is in the youth mental health sector. BC, Quebec, there's a wonderful experiences there. I think there are places where the federal government can provide in a certain layer help so that we can really connect the provincial initiatives which in the end are the ones on the ground and that have to do the implementation. So everyone has their role, but we need to have this complementarity engaged. And
yeah, very well said. And I find the same thing when I am in different regions and hearing about healthcare innovations in parts of the country. And it's very inspirational, quite frankly, when you visit a particular region and you hear through necessity what they've been able to accomplish. And when we sit at a moment where such transformative change is needed across the country, you can't help but wonder, is these case studies and these small successes, are they going to bubble up and be the thing that really takes us into the new chapter? And when I ask people that, they say, not without incredible federal leadership as well. It can't all be grassroots and it can't be top down. It has to be both. And one of the best ways for federal leadership to support is to provide more resources, more incentives to connect, to collaborate, but not with a lot of too much direction. It's providing so that the good things that are already happening have more resources to scale up and grow and spread outside of jurisdictional boundaries. So Elena, you might have some interesting perspectives on that from your perspective.
Yes, I think it is incredibly important for us to all work together instead of reinventing the wheel. We have scarce resources in terms of healthcare capacity, but also research capacity. So we need to efficiently use those resources. But one additional comment on the federal jurisdictions, and also leveraging the comment in the chat from Jennifer about Indigenous populations, for example. Indigenous people's care is the federal jurisdiction. So that is one space where federal government can potentially be driving innovation and advancement. And we know that these communities are at most disadvantaged right now, unfortunately. Chronic pain is not one example, it's many examples. It is all other diseases, but chronic pain is particularly a challenge for Indigenous populations to get any care, unfortunately. So maybe if we prioritize that piece of work on the federal level, we can actually help so many more Canadians and also establish best practices.
That's a great point. And I was thinking about that type of theme right from the beginning when Jennifer shared her story, her powerful story, but then also acknowledged that there are many marginalized groups who wouldn't necessarily have the same resources or pathways to support that she finds herself able to do. And again, though, I really want to commend you on you therefore turning around and using your voice, Jennifer, to help more of us understand that. Jennifer, what else can we do to make sure that people like you don't bear a disproportionate burden for being that voice when you are already going through your own challenges? But also carry on that important work of knowledge, the education that needs to happen, the influencing that needs to happen, so that the people who don't have the opportunity to speak out and up like you are doing can be better cared for.
Thank you. I think it ties into the question you asked me earlier about are there barriers and how can people get more involved? And I also neglected to mention that Pain Canada plays a very strong role in terms of connecting researchers and patients. I think the more patient voices, the better. And so, getting pulling down any barriers, getting as many people, as many voices, and as many perspectives, because as I said earlier, everybody has a different experience with pain. And so bringing that to the forefront, helping trainees understand what it's like to live with pain, or other researchers may not have had that opportunity. Just bringing that to the forefront to the extent that it's possible, keeping the train moving in that respect. Because I appreciate that it can't only be a few voices. Those of us who are able, I do what I can when I can. And there are many of us out there who have great stories, or very important stories to tell. And I think, as was outlined in the action plan for pain, authored by the Canadian Pain Task Force, there are a number of recommendations there that, in terms of my hope, or what I would love to see happen to be able to integrate that more, is they're outlined very clearly. And there's so much to be learned from that. The other side that I would say is from a clinical perspective. I mentioned, and a few others have mentioned, the biopsychosocial. My experience was primarily focused on the medical parts of it. I mentioned tests and imaging and surgeries and so on. Very little, if any, of that involved the other part, like what's going on with you, and I think that again ties back to the time clinicians have, and I just can't emphasize that enough. I also think that, that concept, it's been spoken to a couple of times, interdisciplinary, integrated sort of systems, where the systems or specialties can be talking to each other about a case might save time as well, because in the back of my mind, coming from my professional background, I'm always trying to save costs, like better systems and so on. So it's just that can't help but cross my mind, you know, and in terms of prevention strategies. But back to your actual question, you know, how can we keep this momentum going? I think it's just keep people, you know, encouraging people to come to the table, encouraging that voice. You know, there are numerous people who can guide that through. I get questions all the time about how can I get involved, and I do my best to pass them to the appropriate resources. Like, it's about getting more of us involved and getting research involving people from the get-go. And that was mentioned earlier on as well by Helena, just, you know, getting us involved from the beginning in the, you know, grant applications, and, you know, and the whole way through, there's a voice that can contribute.
Jennifer, thank you. And I think in many ways you've helped segue us into this final moment that I wanted to reserve for each of you. Jennifer, you've made a very clear statement about some of the ways in which we can look ahead, say down the road, and where we want to strive to be when it comes to better patient engagement and why. And again, can't thank you enough. But then I'd like to give maybe 1 minute each, and I mean literally 1 minute each, Norm, James, Elena, and Eve, to just say, you know, if it were up to you and in 3 to 5 years, Canada could be sort of in X position or having solved this or that piece of this complex problem, where would you want us to most focus and try to move the needle? Maybe I'll start with Eve.
All right, let's just John. I think to your last point, you know, I think Canada is in a position to be the world leader on this for many reasons, starting with our universal healthcare system. But I think what we have to recognize is that the recognition that chronic pain is a problem in itself dates yesterday. We're just starting this. And now we have the opportunity for mobilizing all the efforts into attacking that problem. You were talking about availability of doctors. Well, it was nobody's business before. Now, with, you know, the creation of integrated clinical settings and so on, we can have people dedicating their time and effort to that. But I go back to what we said before. I think that we need this integrated approach. We need to build the infrastructure to allow this integration. As I said, we have the greatest scientists in Canada on the problem. Let's use that. And I think an integrated infrastructure is going to allow that. And just to close, because I'm the scientist the basic scientist in the room, I think I would still like to point that we need to keep everyone in the loop, and we need to keep every aspect of the pipeline in the loop. I'd like to give one example: the opioid crisis. The Canadian solution so far, if I may allow one criticism, has been on crisis management. The Americans have said yes, of course, but we also need to go back and find alternatives to opioids. Canada is not there. So we need to keep every aspect. I'm the biologist in the room. Let's not forget biology is there too. We need to have all of the continuum in there too.
Very fair.
Have a solution.
And also in keeping with that, just to acknowledge the great point that was made in the chat that you know, folks might turn to all kinds of unhealthy coping strategies to manage pain that goes beyond opioids. And so it feels to me that's also a really important area for us to come back and continue that conversation. So Elena, James, let's go to Elena for a final comment from you, and then James, and then Norm, and then we'll close out.
I think now that we recognize that pain is a problem on its own, we need to share that knowledge, but we also need to collect data, because right now it is extremely challenging to identify those patients in administrative data, in clinical data. So having that collaborative approach to collecting data and implementing data collection in clinical practice. I think it can move the work ahead so many times.
Amazing. James?
Thank you. I guess my last message would be how we can really be set apart in Canada in terms of pain research. I kind of alluded to earlier is about access. And I think there is a major issue with access to therapies within Canada. You know, by and large, a lot of our population lives in urban centers, but there's a lot of the population that lives in the rural community. And in my own practice, I actually have patients that fly in to see me. So they'll stay in a hotel the day before just to meet their clinic visit with me. And when I first started practicing, there was a 2-year wait list to see me. And so to the degree that innovation, whether it be AI, a new drug, a new device, I think the real impact that those technologies can have will be on decentralizing pain. So let's stop focusing on congregation of pain or tertiary care referral centers. Let's put care and mechanisms and options into the patient within their own home, within their local community. And I think it's a problem not only within Canada. I also co-chair the Disparity of Pain Committee at the American Academy of Pain Medicine. Is an issue in the US, is an issue globally. So if we're going to advance the field of pain medicine, not only we have to do the research on mechanisms and the targets, but let's think about once we develop the innovation, how do we get it into the hands of patients?
Excellent points. Thank you. And Norm, our partner in all of this, our esteemed Canadian Pain Network folks, I'll give you the last word on this incredible conversation.
Well, first of all, thanks very much, Alison, for the work that Research Canada does in coordinating events like this. Much appreciated. And, you know, it's great to have an audience. The problems like this are federal and provincial. You know, we recognize the importance of coordinating all of these multiple levels, and having had some experience herding different cats, I can't imagine the challenge of trying to herd this national and provincial and territorial sort of a business. But having said that, everything that everybody says about coordination and making known resources available is absolutely true. We have created in Canada e-consult services that make it possible for physicians to get consults from experts that mean the patient doesn't even have to leave their practice to access the best possible care. We can train clinicians with interdisciplinary pain care treatment programs online so that they manage patients in their own practice. The sort of thing that James was talking about, traveling halfway across the province to see a specialist, isn't necessary. You know, we can distribute those services much more effectively. We can make the public much more aware using things like in the chat, you saw the Power Over Pain portal. Those are resources for pediatrics and adults. There's a knowledge mobilization group specifically focused on pediatric knowledge dissemination called SKIP, Solution for Kids in Pain. You know, all of these things are known. We can drive them out. We can be much more effective. Pain Canada is coordinating this on a national level to try to ensure that we do that. The Chronic Pain Network currently has a knowledge mobilization imperative and an implementation science imperative from CIHR to drive this knowledge into practice and actually have an effect. But, you know, those things need to be supported. And I suppose if I had one request, I would say, you know, look at the action plan for pain in Canada. There is a Health Canada committee, you know, managed by a gentleman named J.F. LaRue, who is leading the implementation of the action plan for Pain Canada within the current Health Canada initiatives. It would be great, in my opinion, for chronic pain to become a ministerial designated activity, a goal, a ministerial mandate, but it hasn't happened yet. But we are trying to piggyback onto other mandates because there's a huge amount of common knowledge and crossover of problems and delivery systems and so on that you've seen mentioned in the chat. So I would look for that coordination, but also parochially support of the Chronic Pain Network going forward and the activities that we've been able to create in the last 8 years.
Excellent. Well, thank you all for being here today, and thank you so much to our panelists for your time and expertise. And couldn't have happened at a more important time during this week that's dedicated to acknowledging the magnitude of these issues. Thank you all, and best wishes from us.